It's like I've opened my eyes again, and the colors are golden and bright again. There's a song in my heart, I feel like I belong. It's a better place since you came along. It's a better place since you came along.
Hello, and welcome to our program. I'd like to thank those of you who have supported our virtual programs throughout this pandemic. And if this is your first time joining us, thank you. I hope you enjoy the program. My name is Nancy Solomon, and I am the coordinator for program development at the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Englewood Health. Englewood Hospital continues to provide outstanding medical and surgical care for patients who come to us from all over the world. We have treated patients from all 50 states and from over 50 foreign countries. Our patients are those for whom blood transfusions are not an option, and they come here to be treated with excellent medical care, coupled with compassion and respect. When patients need either routine or urgent medical or surgical care, they call us for advice, physician referrals, or requesting to transfer their care to Englewood. Throughout today's program, you will see our phone number and website posted. Please feel free to contact us, and we can begin the process of assisting you with your needs. At this time, we would like to introduce the manager of the Bloodless Institute, Ramon Correa, who would like to welcome you all to our program. Ramon, please.
Welcome to our virtual seminar today. We're so pleased that you're able to join us. Today's program will be very interesting, and I'm sure you will enjoy it. We're going to hear from Christine Weiselberg, who is the Administrative Director of the Leslie Simon Breast Care and Cytodiagnosis Center here at Englewood Health. We will also be hearing a presentation by one of our general and bariatric surgeons, Dr. Jingjing Sherman. Also with us today will be Dr. Mahesh Bakina, an interventional cardiologist. And finally, we will see an interview with one of our longtime orthopedic surgeons, Dr. David Feldman, along with one of his patients. I'm sure you will enjoy today's program.
Thank you so much, Ramon. We appreciate your warm welcome. Well, first up on our program, we'd like to welcome Dr. Mahesh Bakina. Dr. Bakina is an associate professor of medicine, as well as the associate program director of the Interventional Cardiology Fellowship Program at New York Medical College. He received his medical degree from Guntar Medical College in India and his master's from the University of Alabama. He completed his residency in internal medicine at Michigan State University and has held fellowships in cardiology and interventional cardiology at the University of South Alabama and Boston University. Dr. Bakina takes care of patients with various cardiac diseases, including coronary artery disease, valvular heart disease, peripheral vascular disease, atrial fibrillation, and heart failure. Dr. Bakina is a member of the American College of Cardiology, the Society of Cardiovascular Angiography and Interventions, and the Society of Vascular Medicine. He is chairman of the Human Resources Committee of Englewood Health Physician Network, director of the NRI Academy of Sciences Medical College and Hospital, India, and president of Heart and Vascular Associates of Northern Jersey. Dr. Bakina is an honored physician with the Bloodless Institute at Englewood Hospital. We welcome you, Dr. Bakina.
Thank you for giving me an opportunity to participate in this bloodless medicine seminar. 21st century is the era for the bloodless medicine. Minimally invasive treatment strategies in cardiology has really revolutionized the care for bloodless medicine patients, and particularly in the field of cardiology. Starting from the diagnosis of the cardiovascular diseases, as we all know, cardiovascular diseases is the #1 cause of death in the United States, both for men and women. Early diagnosis of cardiovascular disease is key in treating these patients with the minimally invasive technologies that will help them to get the best outcomes and decrease the overall mortality and morbidity. The earliest diagnostic techniques that we could do to detect the cardiac disease are echocardiogram and stress tests, which are non-invasive testing that can be done in an office setting. And recent technologies, particularly coronary CT angiogram, which is a non-invasive way of detecting the coronary plaque, calcium, and blockages, which can be done as an outpatient setting, has really revolutionized the detection of the coronary artery disease over the last 10 years. By doing this coronary CT angiogram, these images you can see the calcium that is present and also the blockages that can be detected in the coronary CT angiogram. Once you identify these blockages, then we can decide about the further treatment strategies. Then we go into the invasive strategies of doing the coronary angiogram, detecting the exact blockage and fixing that blockage. The coronary angiogram is a minimally invasive technique. It can be done through the wrist or through the groin with a small puncture, just like the IV catheter that is placed, and with a minimal blood loss of maybe 5 to 10 ml of blood loss. And through this small catheter, we can go up to the heart and see where the blockage is and then fix the blockage. You can see in these slides, this is a patient who came with a heart attack with a complete blockage of the right coronary artery. You can see it's 100% closed. And we are able to open it up and put a stent there, regain the flow, and just stop the heart attack and save the life within 15 to 20 minutes. These treatment strategies, by fixing the heart attack patient with a balloon and stent with minimally invasive technology, really helps them to decrease the overall mortality and morbidity of this patient, and the patients will live longer with much better heart health. And these patients can go home on the same day or within the next 24 hours. So this is one of the key technologies that has really revolutionized the care in cardiovascular treatment for the patients over the last 20 to 30 years. The additional vascular system that is commonly underdiagnosed, undertreated is peripheral vascular disease. Peripheral vascular disease is basically blockages in the leg arteries, which have the same blockages like the heart arteries that will cause pain in the legs and it cause claudication, and the patient will not be able to walk and perform their normal activities. Again, these blockages also can be taken care with the minimally invasive technology of putting a catheter right in the groin or in the arm and opening up the blockages or cleaning up the blockages with a laser catheter and putting a stent. As you can see in this picture, you can see there's a 100% closed artery in the leg and it was opened up, and now it is a complete blood flow to the leg arteries. The importance of this peripheral vascular disease is when patients feel that they cannot walk, they cannot do things, then they will start decreasing their activity and what they can perform, and their functional capacity decreases, and overall their weight gain increases, hypertension increases, and then overall increases the risk of heart attacks and heart disease. And any additional point is about 40% of the patients with the peripheral vascular disease also has underlying coronary artery disease. So this may be an early sign to find out they have heart disease also, and then you can do the appropriate testing and get the care for the heart, appropriate care for the heart blockages that need to be treated. The next big revolution in the minimally invasive treatment strategies in cardiology is TAVR, transaortic valve replacement. Aortic stenosis, aortic valve is one of the major valves when the heart pumps blood. The blood goes through this valve and supplies the blood to all over the body. And this valve with age gets calcified and sclerosed, and it blocks up so that it won't open properly. When it doesn't open and it becomes severely stenotic and tight, at that time the heart becomes stressed and heart becomes weak. Patient develops heart failure and eventually leads to death. The standard treatment for this is open heart surgery, where they will do chest open and remove the valve and put a new valve. But however, for the last 10 years, we have a great technology by doing this TAVR, where we can open the aortic valve via the groin with a small catheter and put a new valve inside the old valve. You can see with these images where we can put the catheter from the groin, balloon and open up the valve and put the stent deployed in the valve. See how nicely the valve is opening. This is one of the major developments in cardiovascular treatment strategies. It is helping several hundreds of thousands of patients by doing this TAVR technology. The next important technology that we should talk about is Watchman device. One of the most common irregular heartbeat that we will see, heart arrhythmias, is atrial fibrillation. This atrial fibrillation is particularly common as we get older. When you have atrial fibrillation, one of the main treatments is anticoagulation, blood thinning medicine. And once you start these blood thinning medicines, these patients will need this blood thinning medicine lifelong. And particularly as you take the blood thinning medicines, there is a high risk of bleeding. And also, particularly if you fall, injure, then it can cause a catastrophic outcomes. So in order to avoid these blood thinning medicines in these patients, the treatment that was developed is called Watchman. The reason for putting this blood thinning medicine in these patients are, the main reason is developing a blood clot in the left atrial appendage, which is a small dog ear-like chamber on the upper side of the heart. That's where the blood clots form, and those blood clots, when they break up, go to the brain, you have a stroke. In order to prevent that blood clot forming and prevent the stroke, we give this blood thinning medicine lifelong. But fortunately, over the last 7-8 years, we were able to develop the new technology Watchman device, where we can put this Watchman device, go from the groin, go up to the heart from the right side, go to the left side, and put this umbrella-like device and close that appendage completely. And in 6 weeks, this appendage will seal off and a membrane will form on it like a normal tissue, and that appendage is completely closed. Once that appendage is closed, then you will not form any more blood clots, so then you won't need any more blood thinning medicines. So then you can stop the blood thinning medicines. I think this is one of the greatest revolutionary thing which helps saving millions of patients, the risk of bleeding, risk of blood transfusions, and also the death because of the bleeding complications. Thank you.
Well, thank you so much, Dr. Becchina. We really appreciated that information. Well, next up on our program, we're going to hear from Christine Weiselberg. Christine is the Administrative Director of the Leslie Simon Breast Care and Cytodiagnosis Center at Englewood Hospital. Christine received her doctorate in nursing practice from Fairleigh Dickinson University and is a board-certified family nurse practitioner. Chrissy has more than 35 years of experience running outpatient medical centers in New Jersey and New York City. As Administrative Director, Christine leads a team comprised of medical pathologists, radiologists, mammography technologists, ultrasound technologists, nurse practitioners, physician's assistants, patient navigation experts, and clinical researchers. She lends leadership also to the hospital's cancer committee. Chrissy is an active member of the National Consortium of Breast Centers, the National Accreditation Program of Breast Centers, the International Honor Society of Nursing, and the National Organization of Women. Chrissy has been closely connected with the Bloodless Institute at Englewood Hospital for many years, working with bloodless patients and participating in public seminars. We are thrilled to invite you to the platform. Welcome, Chrissy.
Well, hello, everyone, and I am absolutely honored and delighted to present to you my talk on patient blood management in breast health and breast surgery. So one may ask why? What is all this fuss about? And why is this such a big deal? Well, it's a very big deal because 1 in 8 women will develop breast cancer in their lifetime. So when you think about that, that's 12% of all women will develop breast cancer. And that's 12 out of 100 people. And it makes me think when I have given lectures in the past to people who are in our Bloodless program, there's usually about 200 women who are sitting in the room. Obviously, that's before COVID. But when you think about that, if there were 200 of you women sitting in a room together, 24 would develop breast cancer in her lifetime. Breast cancer is the leading cause of cancer death in women, and only second to lung cancer. Lung cancer is the #1 cause of cancer death in both men and women. And men also get breast cancer. It's usually 1 to 2% of all breast cancers appear and occur in men. For women who are under the age of 45, breast cancer is more common in Black women, and Black women are more likely to pass away from breast cancer than their white counterparts. 85% of all breast cancers occur in women who have no family history of breast cancer. 5 to 10% of breast cancers occur in women who have a genetic inheritance from one parent. A woman's risk of developing breast cancer doubles if she has a first-degree relative who has had breast cancer. A first-degree relative is a mother, a father, a sister, a brother, or a child. Breast cancers that are discovered because they're causing symptoms are more likely to have spread and are more difficult to treat. So our goal is for women to receive annual breast cancer screening or annual mammography. So some women will ask, well, what increases my risk for developing breast cancer? Well, just age. As we age, as we get older, our risk for developing breast cancer increases. As I had just said, people who have had a first-degree relative, a family history of breast cancer, are also more likely to develop breast cancer. Your risk nearly doubles. People who have a mutation in the BRCA1 or BRCA2 gene. The BRCA genes are normally proteins that are protective of a cell. But if there is a mutation in that gene, the risk of developing breast cancer increases. Breast cancer is more common in white women, women who have dense breast tissue, and women who have previously been on hormone therapy. So what is it that we need you to do? We would like you to get a prescription from your primary care physician, your obstetrician, your gynecologist, and come in for a screening mammogram. However, Englewood Hospital and our satellite centers, we are located in New Jersey. And there is a law in New Jersey that says any woman who is in need of an annual mammography can self-refer, which means come in by yourself without a prescription from your doctor. We prefer that you have a prescription because if there is something that is concerning, we would like our nurse practitioners and physicians to be able to communicate directly with your doctor or a person who is normally in charge of your care. You can see here we have the telephone number for our call center, which is 201-894-3622, and they make appointments for all breast-related imaging and tests. And then you're going to come on in, and here is a wonderful thing about Englewood Hospital and our breast program. We have, at present, 3 locations. One, of course, is the breast center that's on the hospital main campus. The second center is in Emerson. It's called Englewood Hospital Imaging at Emerson. It has been there for many years. And our third location is Englewood Hospital Imaging at Journal Square, which is in Jersey City, which we anticipate will be opening in early 2022. And I think some of you may know where this is located because this is where the Stanley Theater, which is part of the Assembly Hall of Jehovah's Witnesses, is right across the street. So I'm hoping that some of you will want to come to our new facility once it's open. It's going to be spectacular. What you need to know is that at all of our satellite centers, there are the same excellent physicians that you would see if you were here on the main campus at the hospital. So it's the same board-certified, fellowship-trained radiologists, the same pathologists who are involved with your care. And we have a full breast program in each of those facilities, just like we have on the main campus in the hospital. I wanted you to see a picture. This is a picture of just some of the members of our breast care team. And two of our surgeons are off to the right of me. If you're looking at this picture, I'm in the gray in the very front, but that's Dr. Rochelle Leung. And this is one of our newest surgeons, Dr. Gillen, who is off to her right as well. So these are just a few of the members of our team. Dr. Mindy Goldfisher is our Chief of Breast Imaging and the Medical Director of our breast center. She has been at Englewood Hospital for more than 30 years. She is absolutely fabulous. And this is an up-close picture of our three surgeons. Dr. Merle McIntosh is a breast surgeon. She's our Chief of Breast Surgery. And then again, there is Dr. Rochelle Leung and Dr. Jenna Gillen. I wanted you to see what a couple of the modalities look like. The one on the top is our breast MRI, which we recommend breast MRIs for patients who have been diagnosed with breast cancer when a radiologist or the surgeon is concerned that they may need to look at different areas of that breast and at the other breast as well. And then we have mammography, which you see on the bottom right, and of course, breast ultrasound. So what is the process when you decide that you want to come in and you want to get your mammogram, and how do things work? Well, we make it as simple as can be. So when you come to the main campus at the hospital, we have valet parking. I believe our valet parkers are here as early as 6:30 or 7 o'clock in the morning, and they will take your car for you. Our valet parking is absolutely free. At our satellite centers, there is ample free parking. Patients park themselves right outside the main entrance to the facilities. You will meet with a nurse practitioner like myself, and a nurse practitioner is going to sit with you privately alone and talk to you about your medical history, your family history, your prior surgical history. And together, you are going to discuss what type of breast care you will need in the future. She will perform a clinical breast exam, and she will teach you how to perform your own monthly breast exam. You will get imaged, you will receive your mammogram and or ultrasound, whatever has been ordered or recommended, and then you can receive your results. We have the ability here to give real-time results. Some patients, because of their schedules, they may not want to remain in the breast center and they want to receive a call or some type of notification, and we can do that. But we have the opportunity to give you results right away. The other thing that I want you to know is if during this clinical breast exam, if the nurse practitioner feels something that might be an area of concern, she will put a little marker or what we call a BB on that spot. You'll get some additional mammo images. Our radiologist will look at those pictures, and you will go right over to pathology for the pathologist to look at that spot. So when we say a pathologist, we are talking about pathologists that are trained in cytopathology, looking at cells. So if they are concerned about that area, at that same exact visit, they will examine you, talk with you. We could put a little needle, which is smaller than needle that you would get for drawing blood. They call it a little butterfly needle. We take some cells. Those cells are put on a slide, and those slides are interpreted by the pathologist immediately. So if you come in for your annual mammogram, your screening mammogram, and the nurse practitioner feels something that's abnormal or concerning, you will see the pathologist, they will put a needle in it, and you will have an answer in probably about an hour. So that is one of the features about our breast center here and in our satellite centers that sets us apart from any other breast program that certainly I have ever heard of. And I've been here in Englewood for over 11 years. Well, so what are some of the things that you will learn the day that you are here for your breast exam and your mammo? Well, the nurse practitioner is going to review with you about how to examine your breasts. And we recommend that women examine their breasts on a monthly basis. So sometimes people say, well, how am I going to know? How am I going to remember? So if you're someone who is young and you're still menstruating, you get your period every month, you want to wait until after your period is over, when your breasts are less tender and less dense and maybe less uncomfortable. If you're someone who no longer gets their period or menstruating once a month, we say, why don't you do it once a month when the new month changes? So I always examine my breasts the first of every single month. That's how I remember. So we may say to you, we want you to get your mirror and make your mirror one of your best friends. And the reason for that is because we want you to know what your breasts normally look like and what they normally feel like. So we tell patients, you stand in front of the mirror, you look at your breasts in that mirror, you want to see if the skin around them looks the same and if your nipples point in the same direction. Now normally, maybe your breasts don't look the same and maybe your nipples don't point in the same direction, and that's okay. But you want to know if something has changed. And I can tell you that it happens with me when I'm examining patients at least once or twice a month, when a woman will say to me, I got the funniest little dent here, and I never really had that before. And it actually may not be a dent. There may be a lump that she has not noticed that makes the skin or the breast look like it's indenting. So make sure you know what your breasts normally look like. We're going to teach you how to perform your own breast exam. And when you look in that mirror, we want you to look with your hands over your head. We want you to lean forward. And when you examine your breasts, we ask that you examine your breasts with the flat part of your fingers. And the reason for that is fingertips can kind of push a lump or a bump right out of the way. So if you examine your entire breast with the flat part of your hands and your fingers, it's more comprehensive. And don't forget about under your arm. Your breast tissue reaches all the way up under your arm. We call that area your axilla. If you do feel something, do not panic. You call us, and there is no such thing as waiting for an appointment if you see or feel an abnormality. You are given an immediate appointment. So what are some of the symptoms that we want you to be aware of and that we want you to look out for? So any change in the way that your breast normally looks, any lump or hardness or thickness that is in your breast or under your arm, any dimpling or puckering of the skin, a change with the way the skin looks, any nipple discharge that starts suddenly, a pulling in of the nipple or in a different direction than how it normally looks, and pain in one spot that doesn't go away. So mammography alone is not the be-all and end-all. It's also knowing yourself and knowing your body and ultimately knowing your breasts. So a physician once said, the biggest misconception about mammography is that it picks up every single breast cancer, when in fact, mammography can miss 10% of breast cancers. So if you feel a lump that doesn't show up on a mammogram, make sure you bring it to the attention of your physician, of your mammography tech, or the nurse practitioner who will examine you at our breast center. Nurse practitioners examine every single patient who comes in for an annual mammogram unless you request not to have it done. But it's something that is just included in your care here at Englewood Hospital. So what are some of the minor details that we like to tell you about? So women over the age of 40 should have an annual mammogram. Women over the age of 40 should have a clinical breast exam. Remember, this is clinical breast exam by a provider. So a nurse practitioner or a physician or a physician's assistant. This does not take place of your monthly breast exam. We want you to schedule your mammogram when your breasts are less tender, and also some people are concerned about radiation. The FDA, the Food and Drug Administration, has very strict guidelines pertaining to radiation and radiation exposure during mammography, and we adhere to those guidelines. So a few other things that I want you to know about our breast center. We are accredited by the American College of Radiology. We are a breast imaging center of excellence. We're accredited by the National Accreditation Program for Breast Centers and the National Consortium of Breast Centers. We diagnosed more zero-stage breast cancers than any other local or national breast center. We have a top-notch bloodless program that is second to none in this country. We have a talented staff that is made up of physicians, physician's assistants, nurse practitioners, breast surgeons, radiologists, pathologists, social workers, rehab specialists, and we meet every single week, every Wednesday, without fail, at 1 p.m. And anyone who is newly diagnosed from the prior Wednesday with breast cancer, they are presented before this group of about 30 specialists. And all of these specialists will look at your mammogram images, your ultrasound images, your MRI images, your slides, your pathology slides. And together, this entire team will create your plan of care and your steps moving forward. So one other fact about my big hooray for Englewood Hospital as an institution. So I tell people this, and I tell everyone that I know about this, and new people who I meet, and my new patients. So way before I ever started working at Englewood Hospital was my family's hospital. So my husband and I are very close, and we have been married. In 2 weeks, it will be 44 years. And in 2005, we worked in the same building in New York City, in different areas, but in the same building in Midtown Manhattan. And we're very nice to each other, but he called me one day and he said, "I need you, you have to get up here," which is totally unlike my husband. So I went running up these fire stairs to get to his floor and to his office, and he was obviously in distress and not feeling well. So I had my medical team come up, perform an EKG. I took that EKG paper and faxed it immediately to his primary care physician, who said, "I don't want you to panic. I'm concerned. I need you to call 911 or get him to the nearest hospital." So we're in the middle of Manhattan. So right down the street is NYU. We have Bellevue right down the street. There's Mount Sinai and there's Columbia, just to name a few. And I said to my husband, "I'm going to call 911. And he said to me, "Absolutely not. I don't know anybody here. You have to get me to Englewood because if something's wrong with me, I want them to save my life. I'm afraid that here they're going to kill me, and I have to get to Englewood. That's my hospital." And I did what no good nurse practitioner should do, and I'm not recommending this to anybody in this audience or listening to me, but I put my husband in that car, and I drove up that FDR, and I crossed that bridge, and I came to Englewood Hospital. And my husband was having a heart attack, and they saved him here. So this is my place. I feel honored to work here, to give back to this hospital that saved the man who is my entire life and my soulmate. And I promise you that when you come to Englewood Hospital, whether it is our breast center or any other program here, you will receive the most outstanding care that you can receive anywhere else in this country. So thank you for the opportunity to get to speak with you. It has been my pleasure, and thank you.
Thank you so much, Chrissy. We really enjoyed your presentation. Thank you for being here with us today. So next up on our program, we're going to hear from one of our general and bariatric surgeons, Dr. Jingjing Sherman. Dr. Sherman grew up in Baltimore, Maryland, and graduated summa cum laude from the University of Pennsylvania with a degree in bioengineering. She then attended medical school at Icahn School of Medicine in New York City, where she was AOA, Alpha Omega Alpha, the Medical Honor Society. And she stayed at Mount Sinai for her general surgery residency. With an interest in minimally invasive laparoscopy, she completed a bariatric surgery fellowship at the Leahy Hospital and Medical Center in Massachusetts. Dr. Sherman is a board-certified general and bariatric or weight loss surgeon at Englewood Health in Englewood, New Jersey, and a surgeon with Englewood Hospital's Bloodless Institute. In addition, she is a diplomat of the American Board of Obesity Medicine, seeing patients in her office for medical as well as surgical weight loss. Dr. Sherman serves as the Surgical Education Coordinator for surgery residents at Englewood Health. Her clinical interests include bariatric surgery for the treatment of metabolic syndrome, a group of conditions including high blood pressure, high blood sugar, high cholesterol, which together increases the risk of heart disease, stroke, and diabetes. In addition to bariatric surgery and medical weight loss counseling, Dr. Sherman performs minimally invasive general surgery at Englewood Health. Dr. Sherman, we look forward to hearing your presentation.
Hello, everyone. My name is Jingjing Sherman. I am a board-certified general surgeon, and I specialize in bariatric surgery. That means, in addition to general surgeries such as gallbladder removal and hernia repairs, I also perform surgery for weight loss. I have been at Englewood Hospital since graduating from Bariatric Surgery Fellowship and have been part of the Bloodless program since my arrival. When I first started at Englewood, my chief of surgery encouraged me to become part of the Bloodless medicine program. Coming from Mount Sinai, I thought I knew a lot, but I quickly realized that I knew very little about bloodless medicine and how to care for bloodless patients. I was pleasantly surprised to learn about Englewood's world-renowned Bloodless program. Englewood Hospital is a pioneer in the development and advancement of bloodless medicine. The Bloodless Institute welcomed me and took the time to teach me. I learned about treating preoperative anemia to optimize patient outcomes. I learned about the different modalities we have to collect patients' own blood lost during surgery to return back to the patient. I learned about the negative outcomes associated with blood transfusions. I learned about teamwork, how different specialties such as hematology, oncology, anesthesiology, and surgery come together to take care of patients who do not want to have blood transfusions. What a pleasure it is to work at a medical center that prioritizes patient outcome and supports evidence-based medicine on all levels of leadership. In the Department of Surgery, whether it's general surgery, bariatric surgery, or oncologic surgery, we are well-versed in taking care of bloodless patients by focusing on preoperative, intraoperative, and postoperative care. Preoperatively, we take the time to optimize patients. Our bloodless patients all meet with the Institute of Bloodless Medicine to go over options and sign an advance directive, so their health team knows exactly what products they do and do not accept. We treat preoperative anemia so that patients are starting with a good red blood cell count. We treat any blood coagulation problems so that patients are able to form their own blood clots when needed. In the operating room, we perform minimally invasive surgery when possible to reduce size of incisions. We have Cell Saver, a device where we collect lost blood during surgery and return it to the patient. We have various agents to help control bleeding. Most importantly, our surgeons have the technical skill to avoid bleeding in the first place. After surgery, we don't routinely draw blood to avoid iatrogenic blood loss. We give IV iron when patients need it and agents to promote the patient's own ability to make blood. I'm also very fortunate to be trained in minimally invasive surgery, which means that I use small incisions, a camera, and long instruments to perform abdominal surgeries. Minimally invasive surgery has revolutionized patient care in that it decreases postoperative pain and improves recovery time. Most of my general surgeries and all of my weight loss surgeries are performed minimally invasively. Minimally invasive surgeries go hand in hand with bloodless medicine, as it decreases the size of incisions, magnifies the surgical field so we can identify even minute bleeding so we can control it. Small incisions also decrease pain and stress on the body and improve recovery. I'm proud to be part of Englewood Hospital and its Bloodless program. Thank you for the opportunity to share with you what I've learned in my time at Englewood.
Dr. Sherman, we really appreciated that information. Thank you for sharing that with us. Well, we have a nice treat for you right now. We're going to hear from one of our patients and the physician who treated him. We're going to introduce to you Dr. David Feldman. Dr. Feldman is a board-certified orthopedic surgeon specializing in joint surgeries. He is a fellow of the American Academy of Orthopedic Surgeons and a fellow of the American College of Surgeons. As a founding member of the Society for the Advancement of Blood Management, Dr. Feldman uses minimally invasive techniques for patients requiring reconstruction of the hip and knee. In an effort to prolong the life of hip replacements, he pioneered metal-on-metal hip replacements at Englewood Hospital. He has been a proponent of computer-assisted, minimally invasive hip and knee replacements with the use of partial joint replacements and resurfacings. Dr. Feldman serves as Associate Director of the Bloodless Institute at Englewood Hospital and has had decades of experience in treating patients for whom blood is not an option with their orthopedic surgical needs, both at Englewood Hospital and as a consulting physician for patients all around the world. So let's join Dr. David Feldman with his patient, John Cangelosi. Thank you.
Well, thank you, John and Dr. Feldman, for being with us today and sharing some of your personal experience and thoughts with this audience. So we'd like to get right into it. And John, recently you had an experience at Englewood Hospital with Dr. Feldman as the person who took care of you. Can you tell us a little bit about how you came to be a patient and the history of your situation?
Yes. So this goes back when I was about 30 years old, about 12 years ago. I started to experience some pain in my left hip. Didn't really know what it was. Wasn't too familiar with, hip replacement and things like that. So it was actually a friend of mine who encouraged me to see an orthopedic surgeon at that time. So I went to see someone. This was in Edison, New Jersey, and they did the x-rays and they said I had arthritis in my hip. But it was very mild case, but that's what was causing my pain. And they explained to me that if I had, lost some weight and things like that, that I should be okay. But at some point in my life, I would probably need a replacement. So I did that. I went and I lost quite a bit of weight. I lost about 170 pounds and over the past, 10 years, but the pain continued to get worse. Because I was involved in a lot of different activities, riding bikes and playing basketball and different things, and then having children. My children always wanted to play and go outside and do things, and the pain just kept getting worse and worse to the point where, over the last 5 years, it was very difficult to even walk more than 2 minutes. I would wake up in the middle of the night and my hip would be throbbing like a headache. I would even hear the joint crack as I walked or moved in certain areas. I couldn't tie my shoe on my left leg. I couldn't reach my foot at all for at least 5 years, the last 5 years. So at that point in my congregation that I attend, a very good friend of mine, Rocco, he told me about Dr. Feldman, and because he had both his hips replaced. So I said, well, I guess that's probably what I need to get rid of this pain. So I made an appointment and I went to see Dr. Feldman.
All right, great. Thanks for sharing that history, and congratulations on all that weight loss. I'm sure that wasn't easy.
Thank you.
And I'm sure those kids keep you active.
Yes.
And you want to stay active for them, right? So,
yeah.
So Dr. Feldman, again, thanks for being here. So let's let you pick up the story from there. So John, like so many patients, come to you after having maybe months or years even of discomfort or pain. How do you approach a scenario like this with a patient like John?
Well, John, he was a young man with a young family. And what you want to do is you want to find out what is it that the patient wants to do that they can't do because of a hip problem. And we examine the patient, we look at x-rays and different imaging. And after talking to John and finding out what it was that he wanted to do, we made a decision that he needed an arthroplasty or a hip replacement of sorts. The kind of hip replacement he had was a hip resurfacing. He was a very motivated man. I mean, not many people are going to lose that much weight. Mm-hmm. It's tremendously difficult, and it does help. But when you get to the point that you've tried all the different things, trying diet, modification of your activities, if you're getting to the point that you're not enjoying your kids and able to do the things that give you pleasure in life, then, a hip replacement is a reasonable option.
No, thank you. Thanks for that background. So in your particular case, John, you also had concerns about blood transfusion, right? It's not an option for you in your care. So how did that factor into your decision-making around choosing both Englewood Hospital and Dr. Feldman for your care?
Yes, that was very important to me. And because in my congregation, I have friends that have the same thoughts and beliefs. When I went to my friend Rocco and he told me about Dr. Feldman and that it was done at Englewood Hospital, I said, well, that's perfect, because that's exactly where I want to go, because I know they're going to respect my beliefs. I know they're going to have the equipment and the things necessary to monitor that, doing a surgery of that aspect with no blood. And the fact that Dr. Feldman does that in that hospital was very comforting to me. So it didn't matter that I had to drive. I'm about an hour away from Englewood, and that didn't matter. When I knew of Dr. Feldman's history and the success he's had, as well as my close personal friends who've had success. My friend Rocco is almost 70 years old and he goes for a jog every day, and I'm 42 and I couldn't walk. So I said, well, I got to get this done too. I also have family members who are kind of in the medical field. They work for pharmaceutical companies, and they were able to help me on the initial interview with Dr. Feldman. And my brother actually was able to ask a lot of the questions that I wouldn't know to ask when it comes to the treatment plans and how things work. And between my brother and I, very confident that Dr. Feldman was going to be able to help me out, especially being in Englewood Hospital and respecting my views of no blood. So that's why I made my decision to go there, even though there was a distance to drive. It didn't matter.
No, thank you for that confidence and that background. So back to you, David, Dr. Feldman, for a moment. So I know something that you do every day, and you've been working with this program, with our program, for a quarter of a century now at this point. So this is sort of an everyday event to take care of patients for whom blood is not an option, but certainly still any kind of hip resurfacing or replacement, it's a big surgery, right, for a patient, and historically had a lot of blood loss associated with it that needed managing. How do you address that in an environment where there's a program, and how has that surgery progressed over the years?
Well, I'm very fortunate to be at Englewood because we started the program in response to a group of the elders from the Order of Jehovah's Witnesses who came over and said, we have a problem. We need a safe place to go to. And, I was surprised over the years to hear the stories of people who would go to other hospitals and, people would sort of badger the patient and try to change their minds about decisions that they've made about blood. I mean, the nice thing about Englewood is this is a hospital with incredible experience in every aspect of hip replacement, knee replacement, any problems that occur at another hospital. We have people sent over all the time to manage. It's really a team effort that I've been privileged to work with the people who started this effort and this program, working with our patients to achieve.
Well, thank you. And we're so honored and happy that you're still with us all these years into this journey. So John, I guess for some wrap-up words, you already sort of alluded to this, that you came a distance to come to Englewood. You certainly drove past, particularly in New Jersey, a bunch of other hospitals, right, that have very capable surgeons and very capable nurses and other physicians. What would you say to some of the folks in the audience today who might be grappling with a health decision? Maybe it's orthopedic or something else.
Well, definitely don't wait. I waited a long time to get this done and lost out on many years of being able to do certain activities. Again, just going for a walk was very painful for me. And again, the comfort I had knowing that Englewood was going to respect my views, Dr. Feldman was going to respect my views, and the fact of how successful he is with these surgeries. I before never heard of hip resurfacing. I thought I was going to get a replacement and that was it. But once I met Dr. Feldman and he explained hip resurfacing and what that entailed and what it meant, that again, it just instilled the confidence in me to go to Englewood. And again, I have a number of family and friends who've had surgeries over the years, and Englewood has been very comforting, very professional. Even when I went there for just the pre-administration testing and things like that, everything was always concerned about no blood and making sure that they respected my views on that. So that was what really drove me to go to Englewood, is that everyone from the people who worked in administration to the surgeon himself, Dr. Feldman, respected those views and were very professional and very compassionate about that. So that really, made up my mind.
And John, how do you feel now? What's your life like?
Oh, I feel great. The things, just putting my shoe on in the morning, tying my laces on that side, it's really, really amazing. I'm able to do so many things now. I'm back to working out, and I take my dog for walks a couple times a day. Playing with my kids. My daughter wants to go throw a football. I go out and throw a football with her. So just those activities have been, you take for granted when you're in pain for so long. Even sitting in a car, getting in and out of a car was so difficult for so many years. Now I don't even think about it. I get in, I get out, no pain. And sleeping, that's the biggest thing. I'm able to sleep now. I don't wake up in the middle of the night with my hip throbbing like a headache anymore. In fact, my hip is stronger than ever. So definitely, I thank Dr. Feldman and the staff at Englewood Hospital for helping me achieve that.
Well, we're so happy in that your life and everything around you is easier to do since you had the surgery. And so I guess, Dr. Feldman, some final words from you. You've been, again, part of the program for many years, have taken care of a lot of patients, wonderful patients like John. What has being part of this program taught you about your own practice as a physician, and how has that impacted your care of all your patients?
Well, one of the things that I will see is people will come in, they'll have a hip done somewhere else. It's interesting the way that they're spoken to. I had a patient the other day come in and tell me that he was advised to donate blood because he's going to need to have a blood transfusion afterwards. And we've actually seen over the years that is not an ideal thing to do, that when one pre-donates, that's how they phrase it, you're actually making yourself anemic. We have all these techniques for blood conservation that have nothing to do with transfusion that Englewood's honed over the last 25 years, including the pre-op evaluation and the accessibility of hematologists and cardiologists and other specialists who are really specialized and experienced in the bloodless population. And you just don't see that everywhere. And it's not just that those people are around. The collaboration between the cardiologist and the hematologist, we are able to talk about the best way of operating on the patient, of preparing the patient for surgery. If there's any workup, we've picked up unusual hematological conditions that patients weren't aware of. There is just a wonderful teamwork between the anesthesiologist and the surgeons during surgery. We have all these different special devices that we've been using and have pioneered over the years. Cell savers, bipolar sealers. We have a situation in the OR where we can have a conservation of your own blood through an in-circuit collection, and instead of wasting.
Reinfusion. Mm-hmm.
Yes. But I think that if you're thinking about just going anywhere for a joint replacement surgery, and if you're concerned about blood conservation and having surgery that's done in an excellent way that respects your wishes and gives you an excellent result, Englewood should be number one on the list. The people
We all
are
agree.
unmatched.
Well, thank you. Thank you for those wonderful comments, Dr. Feldman. John, we wish you many more years of pain-free exercising and running around and whatever you want to. Dr. Feldman, again, from everyone in this audience, thank you for so many years of dedication and for many years to come of taking care of this special patient population. You're very special to all of us. So thank you again for being with us today, both of you.
Thank you.
Thank you, everyone. Well, believe it or not, we've reached the end of our program. And with that, I'd like to reintroduce to you the manager of the Bloodless Institute, Ramon Correa. Ramon, please.
Thank you for joining us today for this important program. We would like to thank our speakers, Chrissy Weiserberg, David Feldman, Mahesh Bakina, and Jingjing Sherman for being here with us today. We would also like to thank our patient, John Cangelosi, for sharing his experience with us. Before you leave the program today, as your sign-off, you will have the opportunity to share your thoughts with us. You can request a physician referral or ask questions, and we encourage you to do so. Please remember that we are here for you to meet your medical and surgical needs, and our coordinators are available 24 hours a day, 7 days a week for emergencies. We are the Bloodless Institute at Englewood Health.
It's my absolute honor and privilege to officially notify you that the Commission on Magnet has unanimously voted to credential Englewood Hospital and Medical Center as a Magnet organization, number 5. Congratulations. Thank you so much.
I am incredibly excited about today's announcement, not just because of the affirmation it puts upon all of the hard work. It gives me the opportunity personally to thank each and every one of our nurses and all of our team members throughout Englewood Health. Thank you and congratulations for keeping all of our communities healthy.
The way we are able to provide world-class academic care in such a compassionate community setting is really, really impressive and really makes me proud to represent our community as a volunteer as a board. Congratulations to everybody on behalf of the community and the Board of Trustees on this amazing accomplishment.
Achieving this designation is no small feat. It's the result of countless hours of dedication, hard work, and community commitment from each and every team member. You should be extraordinarily proud, as I am, of you and your accomplishments. Congratulations.